This is one patient with congenital aniridia, and unfortunately, the other eye was having no vision because these patients may also suffer with glaucoma. And here, this patient had significant cataract along with a detachment in this eye. So, the plan was to operate for cataract first and decide for the best strategy to manage the detachment later on. Now, this is the point where we are entering into the anterior chamber after making a clear corneal incision for phacoemulsification. And as you can see, this is a nuclear sclerosis kind of cataract. And these patients usually have a very thin capsule, and the absence of iris makes the appearance of these cataracts a very different. And the rhexis may run out because these capsules are extremely thin. And as mentioned in literature, I also found that the capsule was definitely thinner than what I have experienced with regular cataracts. So taking care that the rhexis doesn't extend into the periphery, replenishing the anterior chamber with viscoelastic, and gradually, slowly continuing the rhexis. The point here is that you don't have any other support in case you have a capsular tear, either the anterior rhexis enlarges or the posterior capsular tear, because there's no iris at all to rest an iris clip or an angle supported lens. So once the rhexis has been completed, then we proceed for making a side port and doing a capsular hydrodissection. I find that these cataracts are not only little different, but the rest of the things are nearly same. One thing is very obvious, that operating them under topical anesthesia is little discomforting for them because they have a photophobia inherently because of their absence of iris and overall a more protective reflexes for their eye. Performing hydrodissection and also hydrodelineation. Proceeding on for phacoemulsification, it's better to start the irrigation after you have entered into the anterior chamber, just to avoid the protective reflex Bell's phenomena. Burying the phaco tip in the substance of the nucleus and creating a chop. This chop was not complete, so again attempting another chop and then doing multiple chops till you have small fragments left behind which can be emulsified easily. This is a good strategy for any given cataracts, that you break the cataract into smaller pieces, so that once we have done this, we can simply switch to Phaco 2, which is consisting of lesser power and more flow, more vacuum, so as to pull the pieces and emulsify and consume them. The machine here being used is Apasami Associates robot, which has an integrated posterior anterior segment system along with inbuilt laser, which is very convenient when doing posterior segment surgeries. Every care should be taken to preserve the posterior capsule, because that would be the best and ideal situation for placement of a PCIOL. Aspirating out the cortex using irrigation aspiration cannula, and this is a coaxial irrigation aspiration cannula which has a bent tip which facilitates removal from even the subincisional portion. Engaging the cortical fibers at the rhexis border and then either pulling them toward the center or tangentially so as to engage more fibers, and at the same time peeling the cortex away from the posterior capsule. Subincisional area requires tilting the tip in such a manner that it can easily reach up to the subincisional area, and this requires that one should not attempt to withdraw the tip, rather one should attempt to pivot the tip deeper into the anterior chamber so that the infusion line doesn't get blocked by while it is being pulled out. Once the cortex has been removed, one can proceed for implantation of intraocular lens in the bag. This is a single piece hydrophobic monofocal IOL. The leading haptic goes into the bag and the trailing haptic can be comfortably dialed into the bag. This will ensure that the IOL is well centered. Aniridia rings are available, or aniridia segments are available, which have to be used in pair to provide effect of artificial iris. But here we had a bigger problem behind this cataract, that is the retinal detachment. So that was not the plan. We didn't want the pupil to become small in any way so that our vitrectomy or the retinal detachment management does not get compromised. This is the day 1 picture showing some amount of keratitis around the wounds, and this is the day 3 picture which shows the same view from another angle. Thank you.